محتاج احنا نقدر نخلي المحاضرة يعني انجليش وعربي عشان برضو معانا ناس من بره.
لو عايزها انجلش كلها ما عنديش مشكله.
ما احنا مشكلة ان احنا بنعمل انجليش العرب بيشتكوا، وبنعمل عربي الانجليش بيشتكوا. تحاول
طيب
تمانج.
خلاص اوكي.
احنا بس دكتور اسلام يكون جاهز عشان نبدأ التسجيل ونبدأ ان شاء الله.
خلاص انا جاهز دلوقتي و يوتيوب لايف ناو. وهبعت
بس
لكم اللينك.
هتشير يا دكتور على الشات عشان في ناس
هشير لكم
بتسأل.
اللينك على الشات. حاضر
بس اللينك بتاع الشات.
حاضر.
طيب جاهز يا دكتور؟
ها؟
انت
ثانية
جاهز
واحدة
جاهز
بس.
دكتور اسلام؟
ثواني. ثواني بس. I will unmute me now to be عشان بس الصوت. اوكي
تمام.
يعني دكتور احمد احاول اخليها اكتر انجلش ولا عربي؟
والله هنمشي مع الناس كده ونشوف الدنيا، لو في تعليقات هنبلغك يعني.
انا هبدا اتكلم عادي بالعربي ومع الانجليزي اثنين مع بعض. لو انت قلت لي
تمام، واحنا بعد كده نشوف التعليقات الناس
طيب اوكي.
ونبلغك ان شاء الله.
اوكي
دكتور اسلام. طيب بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد النبي الأمي وعلى آله وصحبه وسلم. اللهم اجعل أعمالنا كلها صالحة ولوجهك الكريم خالصة. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. معكم دكتور أحمد فؤاد عن مشرفي كورس أونلاين أوفثا. برحب صديقي وزميلي وأخي وصديقي الكفاح دكتور تاج الدين عثمان، مدرس طب وجراحة العيون جامعة أسوان، والانتيرو سيجمنت سيرجن. فبنرحب بيه ونشكره شكرا جزيلا على تلبية الدعوة، ونطرح له واسفين على التأخير. بننبه بس ان لو حد عنده فيديو يقفله عشان ما يعمل لناش مشكلة، ونبدأ مع الدكتور تاج. فاتفضل يا دكتور واسفين للتأخير.
السلام عليكم. اهلا دكتور احمد. بسم الله والصلاة والسلام على رسول الله. طبعا انا سعيد جدا بوجودي معاكم، وبحب اشكر الدكتور احمد واشكر كل القائمين على المشروع العلمي ده. انا كنت اتكلمت معاكم يوم الخميس على البيز لاين ايفالويشن اوف اكوايرد جلوكوما، ودلوقتي هتكلم معاكم على البيز لاين ايفالويشن اوف تشايلد هود جلوكوما كتكمله لموضوع الجلوكوما. طبعا before I start I want to talk about childhood glaucoma as classification of childhood glaucoma. وكلنا عارفين احنا كنا زمان بنتكلم ان classification of glaucoma كان عباره عن acquired او congenital بس، لغايه ما بدانا نفكر لا لقينا ان في حاجه اسمها نوع من انواع الجلوكوما بتظهر بعد البيرث افتر بيرث، فما بقاش كلها اسمها congenital glaucoma، فبدانا نسميها childhood glaucoma وليها classification خاص بيها. التشايلد هود جلوكوما قبل ما اتكلم على الكلاسيفيكيشن بتاعها احب بس اوضح كلاسيفيكيشن اوف ايدج جروب ان جنرال. في عندنا حاجه اسمها نيونيت معناها ان هو first 1 month of life. اي بيبي delivered first 1 month of life بنسميه نيونيت. بعد كده بيبقى الانفانت افتر 1 مانث لغايه 24 مانثز، يعني لغايه سنتين، ومن بعد سنتين او 3 سنين لغايه الادلت هود بنسميه جوفينايل. عشان كده التشايلد هود جلوكوما ممكن نقسمها ببساطه لانفانتايل جلوكوما اند جوفينايل جلوكوما. لكن اول ما جم يقسموا التشايلد هود جلوكوما لانفانتايل جلوكوما وجوفينايل جلوكوما، لقينا في انواع منها برايمري انفانتايل جلوكوما اللي هي ان احنا بنسميها برايمري كونجنتال جلوكوما، واللي هي البيكشر اللي احنا عارفينها معظمنا باسم البوفثالموس او الاوكس اي. ودي اللي بتحصل في الفيرست 2 years of life او من since birth لغايه first 2 years of life. بعد كده البرايمري كونجنتال جلوكوما ممكن تكون نيونيتال، يعني زي ما قلنا في الفيرست 1 month of life. ممكن تظهر بعد 1 month بنسميها infantile onset childhood جلوكوما. ممكن تظهر late onset بعد سنتين لغايه 3 سنين، ولو ظهرت بعد 3 سنين بيسميها برايمري جوفينايل جلوكوما. طب ايه قصه السكندري انفانتايل جلوكوما؟ لو جينا نتكلم على البرايمري انفانتايل هنلاقي البرايمري انفانتايل هي مشكله العيان بس هو جلوكوما، معهوش لا سيستميك ولا اوكلر انوماليز، هو مشكلته جلوكوما بس، مشكلته في الاي. اما السكندري انفانتايل جلوكوما هو بيشنت بيكون عنده جلوكوما ومعاها ايذر اوكلر انوماليز او سيستميك انوماليز. طبعا اوكلر انوماليز طبعا احنا كلنا عارفين القصه دي، اللي هي زي الموركس اكزنفيلد، زي البيترز انومالي، زي الانايريديا. ومش موضوعنا النهارده ان انا اتكلم بالتفصيل عن كل واحد من دول، انا هتكلم على البيز لاين ايفالويشن ان جنرال. وفي السكندري انفانتايل جلوكوما اللي بيكون معاها سيستميك انوماليز، زي السكندري جلوكوما اللي بتبقى مع المارفان، مع الويمارتشيساني، مع الميوكوبوليساكاريدوزيس اند اكسترا، مع ستيرج ويبر. دي كلها انواع من السكندري انفانتايل جلوكوما. طبعا الموست كومن كوز او الموست كومن تايب اللي احنا بنشوفه هو البرايمري انفانتايل جلوكوما، اللي هو اللي بنسميه احنا البوفثالموس، وهو ده غالبا بيبقى انهيرتد ديزيز، وبتبقى مشكلته الاساسيه هي في كونجنتال انومالي في الانجل، ويبقى الباثوفيسيولوجي بتاعه في اوبستراكشن اوف ايكوس اوت فلو نتيجه ان في كونجنتال انومالي في الترابيكولار مشورك وفي الانجل، ده هيعمل اوبستراكشن للاوت ثرو، فهيزود الانترا اوكلر بريشر، وبالتالي increase of intraocular pressure will lead to optic nerve damage بنفس الميكانيزمز بتاعه الاكوايرد جلوكوما.
طيب دكتور تاج بعد اذنك، معلش بس احنا عندنا تو كومنتس برضه نفس في قصه السبيكنج ارابيك اند انجلش. الناس معترضه على السبيكنج ارابيك فعايزين انجلش كله، خصوصا لو نون سبيكنج اراب. الحاجه الثانيه لو انت بتتكلم من مايك ابعده بس عن يعني انت بتتكلم من سماعه، لو بلوتوث او حاجه حاول تبعدها عنك بس عشان النفس بيعمل زي ده. الكومنتات اللي جات لنا بس عشان الناس تبقى معاك.
اوكي
اتفضل دكتور.
اوكي. Now I will talk about the baseline evaluation of childhood glaucoma, or mainly primary infantile glaucoma, which is the most common cause of childhood glaucoma. All of us know that the infantile or primary infantile glaucoma is a world challenge for all ophthalmologists, especially glaucoma specialists and consultants. Usually the mother come with her baby immediately after birth or shortly after birth, complaining of the classic triad. All of us know that, which is epiphora, photophobia, and blepharospasm, with change of the color of the cornea and enlargement of the color of the cornea, enlargement of the size of the cornea, especially if she has a previous baby with normal corneal size. And she noticed that the second baby or the third baby or this baby has a large cornea than his brother or sister. The mainstay of evaluation when like this come to us is examination under anesthesia, as all of us know that the baby at this age is uncooperative and we cannot examine him awake. So examination under general anesthesia is the mainstay of evaluation of childhood glaucoma. So what we will examine under anesthesia in like this situation? We should examine intraocular pressure. We should examine the corneal size and the corneal clarity. We should examine optic nerve and angle examination. We should do refraction and bachymetry. And if we can do A and B scan, it will be better. And I will tell you what we will see in every point of this. Now we have one problem. Most of general anesthetic agents lower the intraocular pressure than normal, except ketamine, as all of us know, that it will rise the intraocular pressure. So what the choice, what we will do in like this situation? We'll examine the patient under general anesthesia with agent lower IOP or with agent increase IOP. First of all of us as glaucoma specialists or glaucoma consultant like to try to examine the patient with some measures doesn't affect intraocular pressure. And believe me, it can help, like milk sedation. If we ask the mother to milk her baby with good enough feeding and let him sleep. And we can put topical anesthesia, and we can put special eye speculum, and we can examine the patient with tonopain or eye care, or even with Perkins tonometer. And this work well in some cooperative babies. Another thing which I like, before I decide to examine under complete general anesthesia, which is oral chlorhydrate or ketamine. Oral chlorhydrate, we can give it to the baby, but under advice from a pediatrician. Oral chlorhydrate doesn't change the IOP, and it can be given in the outpatient clinic. So, but it has some side effects like nausea, stomach pain, vomiting, and some diarrhea or dizziness. But these side effects doesn't appear or doesn't happen regularly to all the babies we examine. And I prefer to examine all my patients with in the clinic with oral chlorhydrate, and even if in the follow-up after glaucoma surgeries. So if we could not examine the patient with milk sedation or with oral chlorhydrate, what we will do, we should plan the patient to be examined in the OR under general anesthesia. So what inhalation general anesthesia we should give, or we can examine the patient with without affecting or with little affecting on the intraocular pressure. As I told you before, most of the GA decrease the intraocular pressure. The old inhalation general anesthetic was used before, which is halothane. After IV and the mask sedation, we should examine immediately. But the halothane has the side effect that it decreases the IOP about 40% lower than normal. Now we use, or the anesthetist use another type of inhalation, which is sevoflurane. The advantage of sevoflurane, it is fast acting, and it has the ability for rapid recovery from the anesthesia after that, and little decrease of the IOP than the halothane. So most of the babies are examined with sevoflurane. When the patient is examined, sleep with inhalation, and before intubation, because intubation increases our IOP, we can examine the intraocular pressure either with tonopain or Perkins or with eye care. Examination of the IOP is very important because it is one of the mainstay points in examination of the childhood glaucoma. But we should know that what is the normal IOP regarding to the age of that baby. In general, the normal IOP roughly from 10 to 15 millimeter mercury. Above 15, we consider it high IOP. Below 10, we consider it low. But if we talk specifically according to the age, before the 3 months, the IOP will be less than 8 millimeter mercury. This is a normal range. And from 3 to 12 months, the IOP will be from 6 to 9 months, the IOP will be 12 millimeter mercury, and then increase with age 1 millimeter mercury per year. If we know that range, now we know that the normal range of IOP, so we can calculate, we can decide whether the IOP we examined the baby while he is under general anesthesia is high or low. After examination of the general anesthesia, we should go to immediately for the cornea. What is the corneal finding we see? First of all, and the most important thing we should examine in the cornea is corneal diameter. All of us know that the normal corneal diameter after birth is 10 millimeter mercury. And I mean here the transverse diameter, not the horizontal diameter. So the corneal diameter in childhood or primary infantile glaucoma, usually more than 11, sometimes it reaches 13 or 12 millimeter and I mean here the transverse. We don't depend on the vertical diameter of the cornea. Why we don't depend on the vertical diameter of the cornea? Because the sclera encroaches over the cornea, and like this situation in primary infantile glaucoma, so the most accurate is transverse corneal diameter, and as I told you, it will be more than 12 millimeter in the first year of life, and this is highly suggestive. After that, we should go for the clarity of the cornea. Either the cornea will be cloudy or will be clear. If the cornea is clear or cloudy a little bit to the extent that we can examine behind it, we should examine behind it. We can find also habes striae, which is the tear in the distal membrane due to enlargement of the cornea. If the cornea, as I told you, is clear, we go further to examine the posterior segment and the lens. But here there is something I want to highlight, which is if I found opaque cornea or cloudy cornea to the extent that I cannot see anything behind it, even the iris, especially if it is unilateral, we should consider UBM. This is a case, this is a real case of baby with cloudy cornea, but it was unilateral and with enlarged corneal diameter. When we did for him UBM, we find that it is, or this case is Peters anomaly, which is corneal opacity or central opaque cornea with iridocorneal touch. So consider UBM if you cannot see any detail behind the cornea and in severe opacified cornea. After that, if we can examine the fundus in clear cornea or slightly clear cornea, we should see the optic disc. And all of us know that the cupping and the in primary infantile glaucoma is reversible with IOP reduction if the IOP is improved. So examination of the or seeing the fundus is very important also in examination under anesthesia in primary infantile glaucoma. After that, the gonioscopy. Also, the gonioscopy can be done only if the cornea is clear. We can see the angle and we can see any abnormality of the angle. After that, if we can do refraction for the patient to know what is the actual refraction of that patient, it will be well and good. If we can see if there is another anomaly like retinal detachment, like cataract, like optic atrophy, we should examine. If we can do A and B scan, it will be also very good if it is available for us to do. So after examination of the patient under general anesthesia and before the patient is awake, I will decide now what I will do. This patient is primary infantile glaucoma or not. If the patient is primary infantile glaucoma, so the treatment is mainly surgical treatment. And if I have the facility, and I should have the facility in like the situation, I will go for glaucoma surgery that I will discuss later. I will go immediately for glaucoma surgery after informing the parents and taking the consent for that. If the patient cannot be if the surgery cannot be done for any situation, like general condition of the patient doesn't allow to do surgery at this time, or if the parents refuse to do surgery at this time for any reason, we can try medical treatment for till optimization of the condition. So, but the main treatment of primary infantile glaucoma is surgical treatment. The golden idea here is, as I wrote here, the appropriate timely diagnosis and treatment can dramatically change the course of the disease and restore visual impairment. So what is the medication I will try if I will give medication before I will do the surgery? Okay, here it is another challenge. Choose what is the medication I will choose in primary infantile glaucoma. All of us know that beta blocker can cause respiratory complication for adult and also for infants. So if we decide to give beta blocker, we should give it with cautious. Carbonic anhydrase inhibitors is safe in primary infantile glaucoma. Prostaglandin, there is some controversy regarding usage of prostaglandin because it is irritant the patient and can be not tolerable by the baby. Like an alpha agonist, we should not give for a newborn and for infants, especially before 2 years, because it has many side effects, especially headache, especially because it passes the central nervous system and can cause some problem like somnolence, like headache, like seizures for the patient. So we should not give alpha agonist for that primary infantile glaucoma patients. When I will give medication, what is the indication of giving medication for primary infantile glaucoma patient? Usually preoperative or after failure of surgery until I will do another surgery and some secondary cases, or if the general condition of the patient doesn't allow to do for him surgery now. And another problem, but it is away from primary infantile glaucoma, and I'd like to share it with you. What is the ideal anti-glaucoma medication in pregnancy? Carbonic anhydrase inhibitor, it is safe in primary infantile glaucoma, but it is teratogenic in pregnancy, so we should avoid it. Prostaglandin produce uterine contractility, that's why it is not preferred in pregnancy. The beta blocker concentrated in the milk and can be transferred to the baby and cause some respiratory distress for him, and it is relatively better not to be given. Promethazine avoid in nursing mothers because it can be transferred to the baby also and cause that neurological problem we discussed in the previous slide. Now, what is the types of the surgery? Now I examined the patient and I decided to do for him that glaucoma surgery. What is the types of the glaucoma surgeries I will do for the primary infantile glaucoma patient? One, goniotomy and trabeculotomy. And all of us know the difference between the goniotomy and trabeculotomy. We know that the goniotomy is an internal procedure and trabeculotomy is external procedure, and goniotomy can be done if the cornea is clear, and trabeculotomy if the cornea is opaque. But now the trabeculotomy most of glaucoma consultant or specialists prefer to do trabeculotomy even with the cornea is clear, because the success rate of the trabeculotomy is better than the success rate of goniotomy. Also, trabeculotomy can be done more than one time if the surgery is failed, and all of known that how to do it if we do flap and until to reach the trabecular meshwork, and we search for the Schlemm canal, and with trabeculotome we enter here in the trabeculotome and then open the trabecular meshwork until we enter the anterior chamber, and then we try the same thing for the other side. This is trabeculotomy. And now trabeculectomy. Although trabeculectomy is not widely used now a lot in primary infantile glaucoma, but we still have this choice, trabeculectomy, and all of us know how to do it. Combination of trabeculotomy and trabeculectomy, especially if the primary trabeculotomy failed, or if the corneal diameter is high, especially more than 13 millimeter mercury, it will be preferred to do combined trabeculotomy, trabeculectomy. And now the non-penetrating glaucoma surgeries have the upper hand in managing the primary infantile glaucoma, especially deep sclerectomy, because it is very helpful in all types of childhood glaucoma and with very, very good results. It involves dissection of deep scleral flap, then deroofing. We have superficial scleral flap, then dissection of another deep flap, then deroofing the Schlemm canal, and then cutting the deep flap in the aim to do trabeculodesmet window, and the outflow of the aqueous it will be through this window. I want to highlight that really it is the result of the non-penetrating glaucoma surgery, especially deep sclerectomy, is very good in primary infantile glaucomas. We can also do viscocanalostomy. Viscocanalostomy also it is the same like deep sclerectomy, but after finishing the deep sclerectomy, we inject high viscosity viscoelastic inside the Schlemm canal to maintain the Schlemm canal opened. Also, we can do viscocanaloplasty, and it reduced nowadays. We don't do it nowadays because of its complications. Now we will go for glaucoma drainage implants. If all previous surgeries failed to control the intraocular pressure for the primary infantile glaucoma patient, we can now try the glaucoma drainage implants like Burwell valve and OTHMAN valve. OTHMAN valve, it is real valve because it has valve structure and designed to open above L8 millimeter mercury and give good result. But it has the model used in primary infantile glaucoma is FP8, but the one used for adult is FP7. It depends on the size of the OTHMAN valve and the size of the eye. Now, if we reach it to the end stage glaucoma and we have no choices, and or the general condition of the patient doesn't allow to do one of the glaucoma surgeries we discussed, we should go for cyclodestructive procedure in end stages glaucoma like cyclocryo, cyclophoto, or endo laser. Cyclocryo decreased nowadays and we don't use a lot. Like in transscleral diode laser cyclophotocoagulation, we can do it, but I should tell that the response of the child to CBC is much less than the adults, and the children recover faster, and we can do more than one session for transscleral diode laser cyclophotocoagulation, especially in end stages of glaucoma or as a temporary procedure if we could not do angle surgery or non-penetrating, or if there is any abnormality in the angle inhibit or make us cannot do the surgery. This is endo laser cyclophotocoagulation. Here the probe is different. The probe consists of 3 parts, which is the laser part, image part like fiber optic and light source part, and it shows the ciliary processes, and we cauterize or photocoagulate the ciliary process itself. Now I finished, and I want to highlight 2 points. The one thing required for success of any glaucoma surgery is to maintain flow, aqueous flow, and the principal and most challenging complication is to prevent scarring. This is our idea. If we know that, we can succeed in the treatment of any surgical procedure. The first thing I should highlight, there is 2 differences between the target intraocular pressure and pathological intraocular pressure. Not all the normal range IOP is not pathological. So that the target intraocular pressure is the intraocular pressure. When we reach it, the pathology stops to happen in the optic nerve and the visual field. Another thing, after treating the primary infantile glaucoma patient, and the patient, inshallah, succeed, this is not the end for the treatment of the baby. We should consider, or should put in our mind a very important point, that the visual rehabilitation of that patient. So after finishing our role as glaucoma consultant, we should refer the patient to a refractive consultant to manage the refractive error of the patient, which happened due to increase the axial length of the globe, a high astigmatism, or even if we did successful glaucoma surgery and still there is opacified cornea, we should send the patient to a refractive consultant to manage for BKB, but this happened after 2 years. So we should not stop after the patient again normal intraocular pressure. So we should consider treating the patient until we reach good visual rehabilitation and good intraocular pressure. And thank you for you all, and I'm happy to be with you today. Thank you.
Thank you, Dr. Tag, for this nice lecture. We have some of the some raising their hands now. So first of all, we will take questions.
Okay.
So Dr. Amr.
Dr. Amr.
Hello.
Yeah, تفضل Dr. Amr.
Thanks, Professor, for this great lecture. I just have a question about micropulse cycle diode. If you have any experience, you can benefit from us.
Really, micropulse now has the advantage of ordinary CPC, because the hazards effects of the laser is much less than the CPC. But I don't have much experience with it.
Would you try to perform micropulse for some patients?
Sure. If I decide to do CPC, sure, it will be better to do micropulse better than do ordinary CPC. Sure.
Okay. Thank you, sir. Thank you.
Okay. Muhammad Shaheen.
السلام عليكم.
عليكم السلام.
شكرا Dr. Taxis for a nice lecture. I would like to ask about carbohydrate dosage in the infant or neonate, and also another question is the use.
What is the first question? I'm sorry. What is the first question?
Carbohydrate dosage in.
Carbohydrate, yeah. Yeah.
Yes, and another one the usage of mitomycin in the deep sclerotomy or viscoelastic.
Use of mitomycin with?
مع trabeculectomy or deep viscoelastic, deep sclerotomy.
Yes, okay. Okay. Regarding the oral carbohydrate, we are not the one as ophthalmologists should decide the dose. And we should not give it, even if we know the dose, we should not give it by ourselves. We should give under care of pediatrician, as I told you. And we should not give we should know the dose and prepare it and give it to the baby immediately and examine the patient. It should be done under care of pediatrician. This is from my point of view. The exact dose, I don't know. Regarding the mitomycin, sure, the use of the mitomycin with deep sclerotomy.
Yes.
Because we do double flap and we depend on the trabecular desmato window, so there is no need to use mitomycin, and it has no big role in improving the condition. The condition depends on mainly the roofing of the Schlemm canal and good designation of trabecular desmato window.
Okay, but can you use with trabeculectomy?
Sure. Sure. Some glaucoma consultants use mitomycin or anti-fibroblastic agent like this as a routine in all cases of trabeculectomy. As a routine, especially in primary infantile glaucoma, it should be used because the reaction is high in primary infantile glaucoma or in infant. The reaction is high, so the scarring rate is high. So it is better to use, and it is one of the indication of use of like these materials, mitomycin especially.
Thank you, doctor. Thank you.
دكتور رامي عزت. Sorry يا جماعة, احنا we have who are raising their hands. This comes one by one. So next one is دكتور رامي عزت. تفضل.
معلش قبل حاجه بس دكتور، طبعا احنا معانا دكتور عصام عثمان، طبعا ده استاذنا كلنا، كان رايد على السؤال اللي فات بتاع الميتومايسين، كاتب mitomycin is essential in all glaucoma surgery in our population include children. طبعا totally agree with دكتور عصام طبعا.
اوكي.
اتفضل.
دكتور احمد يحيى.
Thank you very much, dear doctor, for your informative lecture. My question, you said that the prostaglandin isn't used in infantile glaucoma, but you didn't mention the cause. Is it because of the systemic problem or other problem?
There is controversial in the using of prostaglandin in primary infantile glaucoma because it is irritant. But it can be used under cautious condition. That's it.
بس only يعني due to irritation?
Yes. You are asking about the side effects of the of it on,
No, my
on
question.
infant.
Sorry, my question is that why the prostaglandin isn't used in infantile glaucoma?
Isn't used?
Yes, you say it isn't used.
I said there is controversy regarding using of prostaglandin. It can be used, but it has irritant effect on the infants.
Okay, is it effective or not?
Sure, it is effective, but the main treatment of primary infantile glaucoma, not medical treatment. The main treatment of primary infantile glaucoma is surgical, and if we try to use any of the medical treatment or anti-glaucoma drops, we use it temporary until we do the surgery. But we cannot use any of even the safe drugs for life for the infants.
Yes. Second question, you said in the pregnancy that there is no safe drugs for the pregnancy if the patient has a glaucoma.
Yes,
what do you give if the patient has a glaucoma and pregnant?
Usually,
the safest drug.
From my experience, I prefer to do for the pregnant woman selective laser trabeculoplasty (SLT) and to stop medication and the close follow-up for that patient. But I don't prefer to give medication.
If the patient refuses, the alpha agonist can be used?
No. Better not to give alpha agonist because it can transfer to the baby and he has CNS problems.
Okay, thank you very much.
In all my pregnant patient, I prefer to give for the to do for the pregnant female if it is open angle SLT.
Okay, thank you very much.
You are welcome.
If you let me to add the comment, Dr. Tag. First of all, for the prostaglandin in children, the problem is that it can cause fat atrophy around the globe, especially in young child. So it will have a black halos around their eyes. So it's better to be avoided. In pregnancy, the safest is brimonidine in first trimester. Third trimester is contraindicated for its CNS depression, and in lactating also for CNS depression. But in second and third trimester, you can use any anti-glaucoma with caution and close follow-up. But anyway, as Dr. Tak said, it's better to discuss first with the patient for the SLT and surgery even before the conception. This is my comment, and I think there is a lot of comments on the chat for this also.
Yes, thank you very much.
Okay. Thank you.
Allah yazak. Our next question was Dr. Rami Azzat. Dr. Rami.
Assalamu alaikum.
I
wanted to ask about I think the same question. What is the drug of choice as a temporary till we reach the surgical period? Because sometimes we have neonates in the SCABU unit and we have internal referral to see a cloudy cornea. We see all the signs of congenital glaucoma. And I'd like to have some medication, topical medication that I will give to him till we can do for him the surgery and he comes out of the unit. This is my first question. Second question is the same. I think the doctor already answered it. Is the drug of choice in pregnancy. Thank you.
Thank you. It is answered. Dr. Islam answered that question regarding the safest in pregnancy. And in children, I said that the drug of choice in children, we can give beta blocker under cautious condition, okay, and carbonic anhydrase inhibitor. Or combination between beta blocker and carbonic anhydrase inhibitor until we do the surgery.
Yes, the temporary measure, as Dr. Stak said, this is a temporary measure until the main aim here is surgery, as Dr. Stak said. The medical is just temporary, just until you prepare for the surgery.
Yes.
Next is Dr. Kishore.
Hello, yes. I'm very glad and very happy for having such a good lecture in English on this congenital glaucoma. My question is that exactly how gonioscope is done. What gonioscope do you use and what gonioscope should be used? Because we have so many types of gonioscope. So how exactly and which gonioscope is being used?
Yes, I will show you here this coib lens. We can use it in the gonioscopic examination of the infant. Also, Barkan can be used. Sometimes we use handheld Zeiss, but the most commonly used coib and Barkan. Sorry, coib lenses. I'm sorry, coib lenses.
Okay.
Next, Dr. Ayman Lonemi. Dr. Ayman.
Alambik, very nice lecture. Thank you for your effort. Thank you for this very nice lecture to TAG. Thank you for all the organizers. I would like to highlight some point that TAG has mentioned, that the importance of amblyopia management, and I would like to highlight that its management doesn't start after finishing the job of the glaucoma consultant. It should be hand in hand, like the last slide in the presentation. It should be hand in hand, especially when you are talking about a child which is a few months old. The amblyopia will not wait for 2 or 3 weeks. It can be dangerous. So we should start the amblyopia management and the refractive error assessment and the refractive correction very soon. And it's better to be hand in hand between the glaucoma consultant and the pediatric ophthalmologist. This is what I think.
Yes, totally agree, Dr. Ayman. Totally agree. And thank you for your comment.
Sometimes, because I'm a pediatric ophthalmologist, but I'm not doing glaucoma patients. So sometimes I face by patient ending in examination under anesthesia with glaucoma consultant, they refer to me. So we can, if we can collaborate and make the same examination for the glaucoma assessment and also for refractive error assessment, this could be much beneficial with the patient, and plus the starting of the amblyopia therapy. Thank you.
Thank you, Dr. Ayman. I totally agree with this. And I want to highlight that it is very important not to forget the rehabilitation of the vision in primary infantile glaucoma, because it is a very important issue, exactly like normalizing IOP. So we should work hand in hand. I totally agree on this.
Thank you. Thank you.
Excuse me, Dr. Tag, for those who are asking for the recording, it's already recording and broadcasted on the YouTube live now. Our channel is online OFSA, so you can follow it, and it will be recorded and broadcasted on the YouTube, inshallah.
Okay.
Sorry, I just want to mention something, because we can, the main computer may, its battery is dead, so we may have a problem, but if we need to continue, we will enter again from another computer. So but we will, inshallah, we will continue. We have another question from Dr. Amro Rabi.
Yes, sir. Yes. Sir, what is your your preferred type of surgery for this type of glaucoma?
Okay. Usually nowadays I prefer non-penetrating glaucoma surgery, especially deep sclerectomy. In all types of childhood glaucoma, it has a very good result from my clinical experience. So I prefer to do that deep sclerectomy.
Do you find
even as a primary procedure, even before doing trabeculotomy?
Do you have, sir, any comparative results between implants and deep sclerectomy?
No, I consider implants like Ahmed valve is last choice for me, not as a primary treatment. Primary treatment differs from treatment of repeated glaucoma surgeries. So I prefer all as a primary treatment, deep sclerectomy, and if failed one surgery or two surgeries, and the patient come to me with multiple surgeries from other colleague, I prefer to do Ahmed valve, but as last chance for the patient, not as first chance.
And what about express valve?
Sorry?
What about express valve?
Express
shunt, yes.
No, it is not used in children. It can be tried in acquired glaucoma and adult glaucoma, but in children, I haven't used it before, and I don't think it is good choice for primary infantile.
I see some big name surgeons do express shunts for infantile glaucoma.
Really, I don't know.
Okay, طيب.
I don't prefer to do it because it has a high failure rate even with acquired glaucoma. So why I put the patient in failure rate, especially primary infantile patient. She needs to be the surgery need to be succeeded from the first time. Better to redo another surgery for the patient. No, I don't prefer to do it.
Okay. Can you, sir, tell us, do you do gonioscopy for every case you meet in your clinic?
Really, no.
Infantile glaucoma, I mean?
Really, no. Really, no. If I have a COIB and the facility is there, I will do, but not all the patient. I depend mainly on the IOP examination and transverse corneal diameter and examination of the fundus if it is available. This is the most important. Even before what? I don't hear.
Surgery. If you are choosing to do surgical.
Sure, better to do gonioscopy for all glaucoma patient, either childhood or acquired. But especially in childhood glaucoma, we depend on the surgery. The main treatment is surgical treatment. So if you have the facility to examine the angle and you have the COIB angle, it will be very good. If not, we can depend on your examination on the intraocular pressure and transverse ocular diameter, and you can decide surgery on this.
Okay. Do you find it better to do gonioscopy or to ask for UBM?
No, UBM can be done, as I told you, especially in cases with opaque cornea and I cannot see the angle. And if I can do the gonioscopy, it will be better than to do UBM. It's in primary childhood glaucoma. That's why. So examination of the angle by UBM or by gonioscopy, if available. If not available, we can depend on the intraocular pressure and the examination under general anesthesia.
Okay. Thank you, sir. Thank you.
Okay, next is Dr. Naif.
السلام عليكم. ما ادري الصوت واضح ولا مو واضح؟
واضح. اتفضل دكتور نايف.
عليكم السلام دكتور نايف.
يا مرحبا دكتور. It's very nice and I'm very glad to hear you, Dr. Taj, after this, and we are missing a lot here in Saudi Arabia and hope to meet you soon. Thank you for this nice comprehensive lecture. Our practice here, as you mentioned, we do primary procedures, deep hysterectomy, and for those who are asking about the second procedure, usually we are now doing another deep hysterectomy with micro-assisted, microcatheter-assisted 360 trabeculotomy. And we noticed that it has a good rate of success rate here. Regarding the implants, as you said, Dr. Taj, it is in our choice, in my choice, it will be the last procedure to try it. My question for you is it a routine practice in Egypt to do a deep hysterectomy, or is there surgeon preference between center and center? Because here I think we are all agreed to go for deep hysterectomy, as much as I know of glaucoma center in Saudi Arabia.
First of all, thank you, Dr. Naif, and really I'm so happy that I heard your voice again, and I wish to see you again. Totally agree with you that the primary procedure is deep hysterectomy, and even if it is failed, I can do another one. And by the way, this idea, this regime, I believe that I have this experience from my work in Saudi Arabia, which I was happy that I was there before, and in Egypt to have another choice where until this time most of the centers do that routinely. If the cornea is opaque, do trabeculotomy. If the cornea is clear, we can do goniotomy, and we can repeat trabeculotomy more than one time, and if it is failed, we can do trabeculectomy. And now I'm trying to change this idea to the idea I learned in Saudi Arabia, and I'm proud that I learned from there to put the deep sclerotomy as a primary procedure in all childhood glaucoma.
Our last comment from Dr. Assam Osman. He is unmuted now. If you want to comment, Dr. Assam. Dr. Assam Osman.
I can read the comment of Dr. Assam Osman. He said to everyone, Dr. Assam Osman, first, he is one of the very eminent glaucoma surgeon in the Middle East, if not in the world. Dr. Assam said that in children, better to penetrate the deep sclerectomy and do penetrating deep sclerectomy because we cannot do gonio puncture in children. So trab alone with or without express has high failure rate. And this is the comment of Dr. Assam Osman.
You can hear me, Dr. Tag?
تفضل دكتور عصام.
السلام عليكم.
عليكم السلام ورحمة الله دكتور عصام.
أخيرا نجحت إن أعرف أدخل. I have a problem actually in using my computer.
حبيبي يا دكتور عصام.
This is very nice lecture. I appreciate Dr. Tag everything you mentioned with regard to congenital glaucoma. Thank you very much. تعليقي بالنسبة للسيرجري actually it is optional يعني. If you can do goniotomy in a clear cornea in mild cases, this is okay. Actually, what you are doing here either combined trabeculotomy or penetrating deep sclerectomy. Why I prefer to do penetrating deep sclerectomy? Because actually cannot do gonio puncture after surgery. But if you have a case with mild congenital glaucoma and the cornea is not bad and the pressure is not that high, you can go for deep sclerectomy as you mentioned, provided during surgery you have good percolation of aqueous through trabeculodismat window. Actually, surgery is optional for everybody. If you can do trabeculotomy in good way, you can do it. If you have mild case, you do goniotomy, this is okay. But actually, our cases, as you work with us here in Saudi Arabia, majority of cases are severe congenital glaucoma, difficult to be managed by simple procedure.
Yes.
Hello.
دكتور عصام سامعينك كويس، تفضل.
You can hear me.
سامعينك كويس يا دكتور عصام.
This is my comment actually about surgical intervention as regard the medications. Actually, any medication can be used provided you discuss with the patient, with the mother, I mean the pregnant lady. Provided also you consider the first and last trimester. Majority of drugs better not to be given in the first trimester. And in the last trimester, better to avoid to give brimonidine, because as you mentioned, it can cross to the baby and making CNS depression and apnea. And also timolol should be stopped also before delivery because it may make bradycardia in the children. But otherwise, you can use Torosopt. About prostaglandins, actually in pregnancy, better to be avoided in first trimester in spite of no proof that it can cause abortion. And better to be avoided late because it may make early delivery, and also it is not proved with this very low minimal concentration to have any problem with prostaglandin. But the most safe drug, which is grade B, which is brimonidine, can be used during the pregnancy except before delivery. And also lovely, يعني alhamdulillah, that the intraocular pressure usually is not high during pregnancy. There is some sort of gonadotrophin which makes the glaucoma is more controlled pressure during pregnancy. If you can, as Dr. Tag mentioned, avoid to give medication, it is good. Thank you very much again, وإن شاء الله نتقابل قريبا بإذن الله.
إن شاء الله دكتور عصام، شكرا دكتور عصام. I want to add comment with Dr. Assam. Some glaucoma consultants depend on their decision on glaucoma surgeries upon the corneal diameter. If the corneal diameter from the beginning is more than 13 millimeter, they should go for trabeculectomy, even trab. And if it is less than 13 from the beginning, so they can do deep sclerectomy or trabeculotomy alone.
Okay, I think we have Dr. Raed.
ويعطيكم العافية. أنا طبعا بحكي معكم من الأردن pediatric ophthalmologist و I deal with a lot of congenital glaucoma in my clinic and in my hospital. سؤالي للدكتور تاج الدين، أنت حكيت إنه الcorneal scarring, if there is significant corneal scarring and opacification, you refer the patient for penetrating keratoplasty after the age of 2. يعني بتهيألي that's what I understood from your talk. I think إنه management, optical management and amblyopia management should go side by side with the IOP management and the glaucoma management. Do you want to comment on this? Do you want to correct me if I'm wrong?
لا, totally agree with you, doctor. If the cornea, what I meant, if the cornea is clear, so the role of rehabilitation of the vision is hand by hand with the pediatric ophthalmologist or special refractive pediatric ophthalmologist. But if the cornea is opaque, this is my question to you. What you will do? If I did a successful glaucoma surgery for primary congenital glaucoma for patient with very dense corneal opacity, and the IOP now is safe and is normal intraocular pressure, and what you will do hand in hand with me now if I refer the patient to you? This is my question.
Well, if the child has significant corneal scarring and corneal opacification, in my opinion, I will go for penetrating keratoplasty.
Before 2 years, this is my. That's why I said after 2 years. As far as I know, I'm not pediatric ophthalmologist. I'm not refractive, but I know that the failure rate is very high if the PKB is below 2 years. And
well, the failure rate is high even in above the age of 2. I mean, but again, if the cornea is cloudy and the IOP is normal, I don't think there's too much chance of good vision in this child. So I think doing keratoplasty, even at younger age, even at younger than the age of 2, will be beneficial for this child.
Yes. Thank you very much. Thank you very much, doctor.
Thank you.
باقي معانا واحد بس دكتور تاج، ايفون. iPhone.
Yeah. Could you hear me, please?
Yes.
Yes.
Okay.
Yes.
Can I ask about the timing of glaucoma surgery for PCG? Timing.
Timing of glaucoma surgery?
Timing. I mean, if the child is diagnosed at birth.
Yes. Okay.
So when will you go for glaucoma surgery?
Once the patient is diagnosed, to do surgery immediately after examination under general anesthesia. I should do my plan that if the patient is confirmed with examination under anesthesia, he is glaucoma, I should complete my surgery and not awake the patient and send him again for OR to do glaucoma surgery. So immediately after the diagnosis and with general anesthesia, I should go to the parents, as I told you, and discuss with them that I should complete with glaucoma surgery and do it immediately. And as early as you will do glaucoma surgery for the patient, you will save his cornea from corneal opacity. You will, even if it is cloudy, it can be cleared. So as early as possible. We should put in your mind before you push the patient to do examination under anesthesia, it should be clinically free and he is fit to do surgery immediately.
Hey, Dr. Ahmad Guma, the last one.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Thank you for this great talk. And I ask how you follow the IOP for this thickened cornea and which tonometer is preferred for follow-up. And what is about the choice tonometer under general anesthesia to measure the IOP?
Yes. Doctor, first, in all childhood glaucoma, we can use either Tonopen or eye care or Perkins. Eye care now has the higher chance to because it is easier to use and can be used with more uncooperative patient. This is the first thing. Second thing, regarding the follow-up of the patient, usually a follow-up of the patient after the surgery by 1 week, and with better with chlorohydrate, not to push the patient again for general anesthesia, and examine the intraocular pressure under oral chlorohydrate, and examine the clarity of the cornea. And after that, I can do examination of intraocular pressure under oral chlorohydrate.
Our last question from دكتور أحمد عبد الرحمن. أهلا وسهلا بيه في الميتنج النهارده. اتفضل دكتور أحمد.
ربنا يخليك. السلام عليكم. Good evening everybody. Dr. Tag, I'm so sorry I was confused regarding the timing. I thought it's 7:30 Cairo time, so that I'm just here so that sure I have missed your wonderful talk, as I can see from the comments. It is just a little comment from our colleague that we asked about the time of surgery. It is just my observation, Dr. Tag, that when you operate on the kids very early, like the first few days of life, it's not easy to handle those eyes. And sometimes you have the tissues are very soft and the iris is still vascularized. So it is just, when the baby comes to me, you have one of two situations. Either you are quite sure that the child has glaucoma, or it is just you are not sure of that. If the child is having glaucoma, which is usually diagnosed clinically, PCG is a clinical diagnosis, you don't have to anesthetize the baby, you're just confirming. And I like your attitude of just confirming and then proceeding for surgery, because usually you are quite sure before the anesthesia. But what happens that when the baby comes during the first or second week of life, I tend to send him for a additional couple of weeks, so that the baby is almost 1 month of age, and I give anti-glaucoma at that time until I'm able to operate on the baby in a better situation. It is just my observation from my practice over years, that operating on very early, you know, that a baby who is just born for a few days or a week, it's not easy to handle. So thank you very much. This is just a comment.
Dr. Ahmed, please, first of all, thank you for your comment. But my question, you don't afraid of reversible corneal opacity if you left the patient for 1 month or more, even if with anti-glaucoma medication?
No, the point is that if the baby is having corneal edema, he will present with a corneal edema. That I haven't seen a baby who is presenting with just cloudy cornea, then progress to corneal edema. This is not the story. If the baby is having a corneal opacity, and then you have one of two options: either he's having a corneal opacity that will not resolve with control of the intraocular pressure, so there is some associated pathology, or you have just a corneal edema that will clear. But I never get a baby that is he's presenting with a cornea that's relatively clear and presented to opacity in a month. I haven't seen this scenario, Tag.
Okay, thank you, Dr. Ahmed.
Thank you, Tag. Best wishes.
Thank you.
Okay, Dr. Ahmed Yahya, last question. He raised his hand again.
Thank you very much, Doctor. But one comment, please. You said that in infantile glaucoma, we can do deep sclerectomy. As you know, the problem is in infantile glaucoma is the trabecular dysgenesis. How the aqueous can pass this? Because if the aqueous can pass the trabecular meshwork, no need to do surgery. But the problem is that the aqueous cannot go to the trabecular meshwork. That's why we do surgery. But you say that we can do deep sclerectomy. How can it be effective? The mechanism is not clear for me, please. Can you explain?
Sure, Doctor. Doctor, in deep sclerectomy, we don't depend only on the flow of the aqueous through the trabecular meshwork. We depend on window through called trabecular desmatic window. So we depend on the flow through the desmet membrane and the trabecular meshwork. So the flow not only from the trabecular meshwork through window of trabecular and descent membrane. This is the first thing. Sometimes to overcome this problem, I combine the deep sclerectomy with trabeculotomy, and this is available, and so I can overcome both problem if there is angle problem, and also increase the outflow through trabecular smato window.
Thank you very much. If there is, I read the books on the glaucoma, but didn't mention the deep sclerectomy. If you the source of your procedure, can you?
Sorry, doctor. Sorry.
Sorry. I read books on the glaucoma, but I didn't find any books mention the deep sclerectomy in infantile glaucoma. I didn't know why they didn't mention this.
Can you send me your email, and I will send you materials talking about this?
Okay, thank you.
I will be happy to send you material like this. I will be happy.
Dr. Tag, can I comment? Yes. Dr. Tag, can I comment on deep sclerectomy in the children?
اتفضل دكتور احمد طبعا.
You know, from the yes, when you think about the pathology, that there is usually a membrane on the trabecular meshwork that should prevent the aqueous from going through the trabecular meshwork. But in fact, in the kids, with usually you operate on eyes with a relatively high pressure, you will get great percolation after exposure of the trabecular meshwork. So that I'm quite sure it's even more than the adults. But the problem is that the mechanism of action of deep sclerectomy, it's an external filtering operation. It's like trabeculectomy. So that I think the subconjunctival space scars very rapidly in the kids. And that's why deep sclerectomy doesn't work very well. It's like trabeculectomy. Both, they don't work very well because of the extensive subconjunctival scarring. And that's why we tend to augment deep sclerectomy by adding trabeculotomy at the same time, as you exactly have said, just Dr. Tag. And there are many centers in the world performing the deep sclerectomy on the kids, and they are coming up with good results. But actually, on the Egyptian kids with severe glaucoma, yes, during the operation, you will find great percolation, but don't trust the result of deep sclerectomy alone in the kids. That's what I have seen from the practice over quite long years.
I agree with Dr. Ahmed. Dr. Tag, also from my experience, is deep sclerectomy alone, as he said, this is not quite efficient. And viscocanalostomy with trabeculotomy is a very nice procedure, and we are trying it for many years now, and we have a good results. But for anyone who is doing it, as mentioned, that there's trabecular dysgenesis, and you have to be sure that your Schlemm's canal will be far posterior. So you have to make your flap longer than regular, yes, because the Schlemm's canal will be something like 4 or 5 millimeter away from the surgical limbus that you can see. Yes. And also sometimes you can combine the the mitomycin C below the first flap and the subconjunctival space. Even we are not depending on, in viscoanostomy, we are not depending on the subconjunctival filtration. But anyway, for corneal opacity, as Dr. Ahmed said, if it is starting from the beginning, not just a corneal edema, mostly there is another pathology, and it will not disappear with surgery. And you have to tell the patient, and in their consent, that you will not get, mostly you will not get visual potential in this eye. We are trying our best, but mostly if the cornea is opacified, not a corneal edema, we have to differentiate between the opacification from corneal edema and the corneal opacification from other pathology.
Yes, yes, you are absolutely right. Yes, yes, you're absolutely. Dr. Islam, another point for a corneal opacity that could be a bit recovering, that's acute eye drops. Because yes, the kids, sometimes they can present with acute eye drops, but usually this is not present at birth. So that like a baby having PCG, and then all of a sudden the cornea becomes white. And then at that time, you know, it's a reversible condition. It's usually due to acute eye drops.
Yes, and yes, also, Dr. Ahmed, if you know that some, even after our procedures, we have to know that there is some residual corneal edema. So when we are measuring our intraocular pressure, if we measure the central corneal thickness, this will make a lot of relief for our results, because sometimes you are depending on the intraocular pressure alone, and you know that there is a corneal edema. Sometimes even the central corneal thickness may be something like 700-800 sometimes even the machine is not measuring because it's out of its limits.
Yes, yes. I tend to use more than one instrument for the measurement, including my digital sense as well for the assessment.
Yes, of course.
But if the clarity of the cornea start to start to happen even from periphery, you can consider that you succeeded even if the center is still opacified. You can see that your clearance of the cornea from the periphery. So you can depend on it also.
I think, Dr. Ahmed, if we can share our experience together, sometimes even during surgery, you will know that this cornea will clear or not. Once you do your surgery, if the cornea start to clear at surgery, means that this cornea will survive.
Yes, a very nice observation. Yes.
Yeah. Okay.
Okay, I think this is last question now. Dr. Tag, if you want to conclude.
Thank you very much, Dr. Islam. Examination of the primary or childhood glaucoma is challenge. I want to highlight that even if you did glaucoma surgery and it is succeeded, this doesn't mean that you can leave the patient, and you should follow the patient up even for life. And you should consider also the rehabilitation of the vision of the patient hand in hand with the pediatric ophthalmologist.
Okay. Thank you, Dr. Tag. And I think this is the end of our lecture today. And be ready for tomorrow for the lecture by Dr. Thari Ghait, the use of Kinacort in vitrectomy, tips and tricks. It will be at 7 p.m. inshallah. We have the whole lectures for the whole week. We have Dr. Salwa in Monday, and then Dr. Asam Osman Tuesday, Dr. Khalid Hassan will be on Thursday, and Wednesday we will have Dr. Ahmad Samir also, inshallah. So this week is scheduled, inshallah, and make yourself ready for the timing at 7 p.m. Saudi Arabia, 6 p.m. Cairo local time, or 4 p.m. Greenwich Mean Time. Thank you all, and if you have any comments, we have a group on Telegram called Online OFSA, and we have the YouTube channel also, Online OFSA. We are putting all our lectures. This is the fourth lecture now. You have my lecture on last week, so you have my lecture, Dr. Samah lecture, and Dr. Deep lecture, 3 lecture, and this is the fourth one today. And also tomorrow we are recording. We are putting it on the Telegram YouTube Telegram channel, and we are also putting it on YouTube. Also, we are broadcasting live on YouTube. So we hope that you all enjoy it, and inshallah we will promise you that we will have a great presenters and a great lecture, inshallah, in the next few days. Thank you, and Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much. Thank you. مع ألف سلامة. Thank you very much. Bye bye.
Okay. Assalamu alaikum جميعا.
السلام ورحمة الله.